So we'll talk about cause of hip pain, treatment of arthritis, and then a lot of the topics have been on kind of newer concepts in hip replacement. And so there's things that minimally invasive hip replacement, there's new joint surfaces, new implant design. And so we'll try to talk a little bit about what's new and is changing over the recent past in medicine. We'll laugh a little bit about how quickly medicine moves, and when the recent past is most of this stuff has been around for 10 or 15 years, but it's still kind of considered new in medicine terms. So causes of hip pain, what is it, where is it located, and what causes it? And so the thing that's probably the most confusing, I think, for a lot of patients when I initially see them, is the hip joint's not really on the side of your body when you push on it on the outside. That's a part of the bone that's very close to the hip as an attachment point for muscles. The actual hip joint, this ball and socket in here is deep in the groin, so a lot of people will come with pain in their groin or pain in their buttocks, and initially kind of being a little bit confused trying to figure out what it could be, not thinking of it being their hip necessarily. A number of things can cause pain in that area. As I alluded to, I'm going to talk a fair bit about the arthritis because that's predominant in terms of a musculoskeletal or a joint disorder. That's the overwhelming proportion of pain. But problems in the back, so pinched nerves can cause pain in that area. It's not the most classic area for pinched nerves, but it's certainly something to think about. There's some considerations of something called bursitis, where those muscles I mentioned attach. Then there's some soft tissue stuff, so tears of labrum, which is a soft tissue kind of gasket for the hip joint, as well as vascular problems, hernia. Some GU problems can actually cause pain in the groin as well. So certainly the first and most important thing to think about whenever you're seeing anyone for pain is making sure you know exactly what's causing it, because if you have a pinched nerve and we end up getting to a point of replacing your hip, you're not going to feel any better. So you want to make sure you're treating the right thing. Hip x-rays similar to shoulder x-rays. The hip is a ball and socket joint. I tend to try to make fun of sports doctors a little bit and say that there's a better engineer design in the hip joint because it's a little bit more stable, but the concept is similar. You've got a ball and a socket, and these are the two hip joints on both sides. When dealing with arthritis, joints are supposed to be covering cartilage, which pushes the two bones apart. So on the right side, the left side, you can see a normal looking hip x-ray where you have space between the two bones. And when we get an arthritic hip, we see something like on the right side where you really don't have any space between the bones. There are some other hallmark signs too. You can see these big gray areas that look like holes in the bones. Those are cysts that are normal in arthritis. You can see bone spurs and a few other findings of arthritis. It affects a lot of people. The U.S. population is supposedly something like 350 million, and there's estimated to be over 40 million people with hip arthritis in the country. So short version is there are a lot of people with hip arthritis. Doesn't mean that everybody's hip arthritis hurts them. This is based on x-ray studies, and just because someone has arthritis on a hip x-ray doesn't mean that it hurts them. So the real question is, does it bother you? And if that's the case, then we're going to talk and see what we can do to help you out. So there are many types of arthritis. Overwhelmingly, the predominant is osteoarthritis. It's basically a wear and tear arthritis. It's putting miles on your car tire and the tread gets thin. There's rheumatoid and inflammatory arthritis. That's by the TV commercials would make you think that that's what everybody has because that's all that's advertised, but that's typically a pretty small minority of people. Post-traumatic arthritis, if you've had a bad fracture before, then Dr. Levenda talked about avascular necrosis, where there can be an insult to the blood supply, and that will cause some deformity of the joint and then leads to arthritis. This is just briefly going over so rheumatoid arthritis, like I mentioned, is an inflammatory arthritis, so it irritates the joint lining. Post-traumatic, the irregularities from the injury will cause roughness in the surface, and that leads to arthritis, and avascular necrosis with the insult to the foundation. So osteoarthritis, by far the most common, is the result of using your hip. It's putting miles on your hip. Again, incredibly common, so primary care physicians see this over and over, and frequently will refer patients to us. People go on and just talk to their primary care doctor and have osteoarthritis, and again, estimating that there's tens of millions of adults that are affected by arthritis. So, just because 43 million people have it doesn't mean all of them hurt, but there's estimated to be 25, 30 million people who are having pain in some form from arthritis. People who have osteoarthritis, almost half of them have some form of limitation within their activity, and many patients with arthritis are actively working, and about a third of them end up having difficulties with their work and either have to find accommodations, or some people who are meeting will actually have to change their jobs because of the pain and the limitations they have from their arthritis. And so it has a significant financial impact, not just both personally on the patient, but also in terms of our society in general. So osteoarthritis symptoms, again, Dr. Levenden kind of touched on this, may develop very slowly. You may just have had years of worsening pain, or sometimes your hip doesn't bother you at all, and you end up at some point where you have an injury or twist your hip and it just sets you over the edge and it finally starts bothering you very quickly. It can cause stiffness frequently. Some types of arthritis will have significant swelling with it. Normally osteoarthritis doesn't, and it makes simple tasks very difficult to do. So the diagnosis can usually be made with fairly simple visits in the office. And so history and examination is often enough to tell you pretty reliably you probably have arthritis. X-rays will confirm that, and as often no further testing is needed than that. For a few types of things like the rheumatoid arthritis, there are blood and urine tests for it. CT scans and MRI scans, when it comes to arthritis, there's a lot of questions. Well, should we get an MRI scan to know for sure? In terms of arthritis, usually do not have a significant value. That's a little bit different than Dr. Levenda's world, because the rotator cuff affects what he does a little bit, and the hip, as I'm talking, is a little bit of a different structure, and it doesn't come into play a whole lot. So how do we treat it? So first of all, we try to avoid surgery if we can. And so, we're here in a surgery office, so we talk about surgery, but that's usually our last resort. So diet and exercise, so for every pound of weight that is above your hip experiences about 3 pounds of force. And so even small differences in weight can sometimes make big differences in your pain. Diet really primarily comes into play with weight loss and not so much in any particular foods that help arthritis. Exercise, sometimes is difficult because of the pain, but for people who are able to stay active, it makes people measurably happy, or makes people far less limited by their arthritis. The rest and taking care of the joint, so this is a sugar-coated way of kind of saying activity modification. Again, Dr. Levenda talked about if there are things that in particular that bother your hip, and you can avoid them, you avoid them. Now, you have to live your life, so this isn't saying to stop doing everything, but this is saying that there's an easy way to do things, do it the easy way. Using a cane or a walker takes stress off of the hip. Not many people really like that, but it's an important option to make sure at least everyone's aware of. Medication, so we try to avoid narcotic medications, prescription type pain medications, but people can have a pretty good effective relief from the anti-inflammatory, so relatives of the over-the-counter Aleve, ibuprofen, things like that. And Tylenol can be really good for people sometimes. Cortisone technically is a medication, but I listed it separately because it's usually given as an injection. Because of the side effects, we don't usually give it orally, but as an injection, it doesn't have many side effects. And when we inject a steroid into the hip joint, it can sometimes provide 2 to 4 months of relief. And if it provides several months, it's a fairly easy thing to repeat. People will ask about glucosamine. Those are all those joint supplements, and they've not been reliably shown to have any help for arthritis. And then someone up in the front here, I think she had left, had asked about the gel shots, that's what visco supplementation is. Similarly, it was discussed, it's not approved for the hip. It doesn't really have much of a role. So kind of touching on this in terms of weight loss, if the average person is 20 or 40 pounds overweight, you walk 5,000 to 7,000 steps a day, and your hip has to go through all that stress, and even small changes can take quite a bit of stress off of the joints. Doesn't mean that it'll necessarily losing weight will guarantee that your hip will feel perfect, but it often helps quite a bit. Medications, so we try to stick with over-the-counter medications or similar groups. So for instance, there are a few anti-inflammatories that are prescription but have the same side effects. We don't like to use narcotics because this is a problem that's not going to go away. And again, as discussed, there's been a lot of issues with long-term narcotic use, and the complications from it really just don't outweigh you don't get enough benefit to justify the complications from a long-term use. Corticosteroid injections. People are concerned about these long-term side effects. They talk about stretch marks, hair growth, osteoporosis, all these things. Those are really issues of oral steroids. And so all steroids, either oral or injection, will decrease inflammation, but all the side effects that are really publicized about steroids tend not to be an effect of the joint injection, because almost all the steroid stays inside the joint. It doesn't, very little circulate systemically. The injections they're safe, they're effective, they're cheap, they are temporary. They don't fix the problem, but they can be, if they last for several months, they're simple and effective, they have very little risk, and they're a good way of managing the pain. So joint replacement, when all this stuff doesn't work, joint replacement can be considered. It's considered basically when the pain is severe, it limits activities of daily living, interferes with work, keeps you from doing what you need to do in your life. So the issue, people will say, well, when's the right time for this? I've come to you, I've already tried these over-the-counter medications. Of course, I've modified my activity, I avoid things that bother it. A lot of this stuff people have tried already. Well, the simple version is whenever the right time is, whenever you're ready. And that means different things for different people. Some people, if they can only play 9 holes of golf, instead of 18, they say, I need to do something about this, I need to get this done. Other people say, I really want to tough this out, I don't want to go move forward with it, and that's a balance and an individual choice. There is some information that suggests that there is a little bit easier recovery and improved function doing joint replacement earlier rather than later, but what that really comes down to is if you let your pain debilitate you to the point where you can't do anything, that you get very weak and you just can't get up and move, it's understandably harder to recover. And so it's not an issue that the first time you have any arthritic pain, you need to go talk about doing this. It's an issue of when you get to the point where you just can't do anything and you're getting really weak, then sometimes that's a point to consider, even if you want to tough it out, to consider that your recovery is going to get harder if you continue to get weak and deconditioned. Hip replacement is a very common surgery. The only more commonly replaced joint in the US is the knee. It's been cited in papers as one of the most important operations in the last century, primarily owing to the fact that it returns a lot of people back to their prior level of function or very close to it, and so it can get you back doing the things that are make you happy, helping you exercise so you can stay healthy, and getting people back to work, and again, helping both personally as well as everyone that they work with. So estimations are that hip and knee replacement are going to dramatically increase throughout the future coming decades because it's a problem that we understand more, and so there's more people who are aging and being affected by this. So what we do with a hip replacement is on the right, I'm confusing my directions again, I apologize. On the left, your left side, there's a normal hip joint, and the cartoon tries to show a worn out joint in the middle, and we end up replacing that ball and socket with metal foundation parts and then a synthetic or ball and socket joint, so there's no longer raw bone rubbing on raw bone, which causes a lot of inflammation. There's a very smooth artificial surface made out of typically either metal or ceramic and plastic that doesn't cause all that pain and irritation. On x-ray, it shows a little bit more of these foundation parts that are in the bone, and so the simple version here is that even though it's only the ball and socket that are worn out, we need to be able to mechanically hold those parts in the bone, so we have to use a foundation part that goes a little bit further into the bone. One of the most common things asked about in kind of current trends over the last decade is the, quote, minimally invasive hip replacement. In general, minimally invasive doesn't have a clear definition, but it implies you have smaller incisions, less collateral damage, so less cutting of muscles and tendons, less bone removal. And for the hip, typically refers to what's called a direct anterior approach. So the direct anterior approach is the only approach to the hip, the way of getting to the hip joint that doesn't involve in some level cutting or splitting the muscle. And so it's not necessarily a smaller incision in this case, but there's less disruption of the normal anatomy around the hip. Illustrating this in a cartoon, on your guy's right is the concept of the anterior approach, so it gets to that hip joint by going through those muscles with that blue arrow on the right, whereas you can see the two other arrows basically go straight through a muscle, and so they split that muscle. And anytime you cut muscle, there's more pain, there's more swelling. That muscle itself has to heal before it can get strong and conditioned again. So in terms of a traditional approach versus the anterior approach, the incision does get a little bit smaller. This is taken from a research paper, and I would argue that the 8 to 12 inch incision is a little bit of an overestimate, but the incision still can be a little bit smaller. In particular, though, the fact is that for the traditional hip replacements, we do mess with the muscles around the hip, either splitting or directly cutting them and then repairing them. In the front approach, there are no muscles or tendons that are attached. So the benefits in terms of what does this direct anterior, the minimally invasive approach do, there is less blood loss, there's a shorter hospital stay. That stuff's well demonstrated in the literature and the research. There's less overall damage to the abductor muscles. These are a group of muscles on the side of your hip that are very important for walking without a limp. The other considerations, though, in general, people walk more normal with an anterior approach, and there may be reduced rates of dislocation, less postoperative pain. This has been a little bit more varied in the reports in the literature, but seems to be a reliable benefit. The other thing that's notable is that so after your hip is replaced, it's less stable than your normal hip joint. That primarily comes down to the geometry of the metal parts and the size that we can fit in. And so we have something called hip precautions to reduce the risk of dislocating the hip. And so for traditional hip replacement, if you read through these things, it's bringing your knee up to your chest, it's crossing your legs over. These are things people actually do. They bend over to pick something up and bring their knees up to their chest. You sit and cross your legs. And so they don't keep you from living your normal life, but it makes you think about it a little bit. For the anterior approach, the minimally invasive, it's basically putting your leg behind you and pointing your toes out. People don't tend to really walk around doing that at any real point in their life, and so it doesn't interfere with people as much, and they can kind of, I don't want to tell you to truly put it out of your mind. It means you shouldn't necessarily do that, but if it's not something you're going to do, you don't have to really think about it much. So everything is a trade-off of risks and benefits, and so the anterior approach is not necessarily perfect. Particularly notable is that so two things. One is that there's a higher risk of intraoperative fracture, so it's not for everyone, for people who are going to have really brittle bone. This primarily actually correlates more to people who have hip fractures that we're doing hip replacements for. It's not a significant concern for elective hip replacements typically, but it is something to think about. There is a sensory nerve that is, depending on which research paper, is damaged between 30 and 70% of the time. Now, damage doesn't mean it's cut. What it means is that when nerves are stretched, they go to sleep for a while. And so that nerve can cause numbness on the front of your thigh for between 6 and 12 months after surgery. It does recover, but it's something that if we don't talk about, can surprise people a little bit. Just like Dr. Lavenda alluded to, there's definitely a learning curve and a maintenance curve. And so this is, again, something, if you go to someone who's never done this approach this type of hip replacement before, or only does a couple a year, it's well shown and demonstrated that there is an increased risk of complications. And so the magic number for an anterior hip replacement is someone should have done at least 50 of them in the past and should do about 25 a year to reduce those risks of complications. So the other thing is there are risks. It's also not for everyone. And in particular, the big thing where this comes to is that the people who have a large belly, that belly will start to fold over in the area where the incision is in the front. And skin incisions don't heal very well when they're stuck in a fold between skin. And so the people who start to have that fold, there is a concern for wound healing and infection. And so we are cautious with that. There's certain pre-existing conditions, so the direct anterior approach takes a little bit longer, typically about 20 minutes longer, but for people who have a lot of medical problems, sometimes that extra surgery time is not beneficial to them. And then muscular males are not a contraindication, a reason not to do it, but it's one of the most challenging anterior hip replacements that people will be able to do because you have to fight against the muscles while you're going between them. We've changed the joint surfaces that we use, and this helps to hopefully make the joint last longer. So the traditional surface is a type of plastic and a metal head, and it's typically the plastic that wears out, and we quote 20 years as a survival for hip replacement, usually limited by the plastic wearing out. The bearing surface, so the surface that actually moves, how durable it is going to affect the way it wears, what type of longevity, the durability it has. But the interesting thing is, unfortunately, wear and mechanical strength tend to be opposite. So it has to be so strong to deal with the forces of the hip joint, but the stronger it is, the quicker that material tends to wear out. And so it's been a balance of trying to balance that type of mechanical strength and that wear. So on the left, the two on the left are kind of demonstrating this plastic and metal bearing surface. 40 or 50 years ago, we didn't use a metal shell foundation part, and we cemented the plastic into the bone, but that led to failure of the cement. It's not as strong as the metal interface where bone grows into it. So we moved to using the ceramic head, so that's the pink head, and that in the laboratory reduces the wear about 20 to 30%. And then there is an option of using both the socket and the ball of ceramic. That has the lowest amount of wear, but that does come with a couple other unique risks. So in terms of looking so polymer is a way of saying plastic. So the metal on plastic and the ceramic on plastic, you can see a big difference in the wear rate. You can see this is not a percentage, this is in terms of an actual distance. And ceramic on ceramic has the lowest wear rate. Two unique things with ceramic, and so if you ever break a piece of chalk or you have a ceramic glass, it shatters. So when it breaks, it doesn't dent, it doesn't wear, it just shatters. Now the new generation of ceramics is not very susceptible to that, but it doesn't fail subtly if it fails. The other thing is, interesting enough, the ceramic on ceramic bearing replacements, about 5% of people, their hip will squeak loud enough that you hear it while you're walking by, and so that has not been very appealing. And so we don't do those very often because generally speaking, the ceramic on plastic does so well that there's not much more benefit to doing the ceramic on ceramic. The other thing we've done is we've changed the way the plastic is processed. So it's actually the same plastic, but it's processed differently. And in the laboratory, it resulted in an over 90% reduction in the wear rate. Now that change was made about 15 years ago. So I told you guys that we quote about 20 years for a hip replacement. And so if that change was made 15 years ago, we're still waiting to make sure that makes a difference in actual real live use, but it would seem that the hip replacements are going to actually last even longer than 20 years now, given the laboratory data about how much slower they wear with this new change in the plastic. We've changed the way that implants have been designed a little bit, and in particular, the two big things is so these foundation parts have been coated in metals and materials that have encouraged the bone to grow into them. And it's not that have changed the fact of whether or not the bone grows into it, but we've made it much more efficient. So the bone grows in much stronger and more efficiently, has a better interface. And so those foundation parts I talk about that sit in the socket and the thigh bone, ideally and conceptually should never have to be changed. It will be really solid. And so even if you have your hip and you wear it out after 25 or 30 years, it's hopefully a much simpler process of going and changing those two mechanical interfaces with the ball and the socket. Basically kind of more like a tire change than it is a full redo of the hip. The other thing we've done is we've used larger balls in the ball and socket. So as the materials have gotten a little bit better, we can make them thinner so they take up less space, which makes more room for a ball. And the big thing that does is it increases the amount of stability of the hip. So I mentioned that the replaced hips have a little bit of a higher risk of dislocation, but by using these larger heads, that decreases dramatically. It also allows for a greater range of motion, and so using this graph is at some point, basically the attachment point for this head called the neck will start to impinge on the socket, or the socket will get in the way and keep it from moving. So the larger the ball is, the more motion, the larger the arc is before that starts to happen. So you get more motion out of it. And so in terms of how does that matter in terms of daily life? Well, some of those smaller heads were limited to 60 or 70 degree arcs. So if you look at things like going up and down stairs, sitting in a chair, you start to push that limit with some of your daily life, whereas most of the constructs that we use now do allow for 140 or 150 degrees of motion, and so that covers pretty much anything that most people would want to do in their normal life. This is just a nice picture showing the concept of motion at the hip. Another thing that we've become much more knowledgeable about and paid a lot more attention is managing risk. And so, as Dr. Levenda mentioned, nothing is risk-free, but things can be much lower risk. And the lower your risk is, the happier people on average will be with their hip replacement because there's fewer problems that are affecting people. So things that are at risk with a joint replacement include infection, bleeding, problems with wound healing, as well as general medical risk. So things like your heart, your lungs during the time of surgery. So managing risk, we know that it is actually really helpful to help people lose weight if they're significantly overweight. Now we use a body mass index with this, and that basically adjusts your weight for your height. So this doesn't mean that if you're the average American a little overweight, that your risk is significantly higher. But if people have a lot of weight to lose, it actually really helps them if we can help them lose weight before rather than after surgery, both to make their recovery easier as well as to reduce the risk of infection and wound healing problems. Medical risks, so diabetes, for instance, if we can help you manage your diabetes well, then we can reduce the risk of infection as well. A lot of people will already be well managed when they come, but if not, then it's a good time to sit and say, let's talk and work on this for a month or two and make this a safer surgery for you. Lifestyle issues, so smoking will both improve, quitting smoking reduces your medical risk as well as reduces risk of wound healing problems. And then general medical problems that if there's something we can do to make that a little bit better managed, it really reduces risk of medical complications. So again, things like heart attack, stroke, things like that during the surgery. The expectations of a joint replacement, so if you say, well, okay, I have to do this, is it really gonna help me? What can you expect? So the primary goal of alleviating pain, of a joint replacement is always alleviating pain. It's very reliable for alleviating pain. The joint replacement will improve your motion and your strength as well, but the effect of your pain is the 97-99% effect. Recovery, everyone's a little bit variable. Dr. Levenda had brought up the idea, and see if I would argue with him about every 12-month recovery. I do agree with him that you get to your maximal improvement takes about 6 to 12 months, but within 3 months you usually feel pretty functional. And so most people will stay in the hospital for 1 to 3 days. However, depending on the patients, it is possible to be done as an outpatient surgery as well. The significant functional improvement, so between 6 weeks and 3 months is when you're kind of getting back to your normal day-to-day stuff easily. And so it doesn't mean that you're not going to be back to going out to the store or dinner within a couple weeks even, but easily not having much difficulties. But between 6 and 12 months is when people tend to find their maximum improvement. There's a handful of things like stiffness when you first get up, some soreness with weather changes that go away over that first year. The outpatient total joint replacement, so I mentioned this can be done potentially as an outpatient total joint. The simple version is there's no place like home. Your hospitals are, I'm stealing actually one of Dr. Levenda's lines here, but hospitals are typically something that's better for sick people, and people usually having their joint replaced are not sick. They just have a mechanical issue with their joint. And so there's people who would want to think about doing this as an outpatient are going to have good support at home, are going to be in good health. They're not going to have a lot of weakness that's going to keep them from having an expedient and normal recovery. In terms of things to expect to get back to and going back to your routine, people will ask about going up and down stairs. That's a big issue a lot of times at home. Almost always you'll be able to do this before you leave the hospital. You should have no real restrictions in terms of safety when you go home, so that you're going to need to be sure you have good balance, but you're not going to be restricted in terms of saying you can't walk or you can't go up and down stairs or you can't do more than this. You're going to be able to do anything you're comfortable with. In terms of going back to driving, back to work is particularly individual and highly. So for instance, work, what do you do? So if you have a desk job, I've had patients that go back within a day or two after surgery, often within a week or two is easy. But if you're a construction worker, it's going to take a little bit longer. You've got much more in terms of what you need to be able to do. On average, going back to driving is about 2 weeks after a hip replacement, but again, it depends on each individual. So after surgery, we talked about there are certain limitations in terms of the motion in your hips, so to reduce that risk of dislocation. When you're fully recovered, I expect patients to be able to go back to work. Depending again on what your job is, you may be able to go back before you've been fully recovered. Some types of work aren't necessarily the easiest for people with joint replacement. This isn't so much because of the joint replacement, but it's because it's physically hard work. And so, construction work, carpentry can be a little bit tough because of climbing the ladders, but most people should be able to go back to their jobs. Limitations. There's no true limitations after surgery, but we generally discourage high impact and high risk activity. So what we mean by that, so basketball, contact sports, those are high risk in terms of falling, breaking things. Running is a high impact, is a frequent, so it's just an issue of if your joint is going to last you for 50 million steps, you don't want to use that up in 10 years, you want that to go for 30 years. After a joint replacement, so in terms of realistic expectations, you should not have any pain with reasonable physical activity. You should be cautious though in terms of, like I said, high impact activities. Longevity I've already touched on a little bit. We quote 20 years, but this is a little bit variable as well. So in particular, the biggest variable with this is the younger you are, typically the more you use your hip replacement. So it's been shown to wear it a little bit quicker in younger people. This does not mean half the time. This means that it changes things by a couple of years. The other thing with the 20 years is what, in general, when we say 20 years, people think that's an average. Only half of hip replacements are left around. For whatever reason, the way we came up with this as a community, as orthopedic surgeons, we decided to say whenever there's only 90% of hip replacements, they're still functioning well. And so at 20 years, 89% of hip replacements are still in place and functioning well. So it's not an average of, you have a 50% chance of 20 years if it'll still be there. Most likely at 20 years, your hip replacement will still be working well. Any questions?